Does this sound okay? Because I'll not be doing calculations here. I want you to attempt those calculations based on these. Because if I solve everything for you, you will not have that instinct of solving it well on yourself. So have your doubts, then we'll discuss the doubts. Okay? So after this we move on to our anesthetic techniques. Okay, this is gonna be a fast-paced thing. I know you all know all the techniques and all that, isn't it? This is something, an easy part of local anesthesia. This is something which we do, isn't it? So let's move on with a casual discussion with it. So there are three things: the local infiltration, the field block, and the nerve block. Local infiltration is very local, wherein we just put the local anesthesia in the terminal nerve fibers. Field block is a little bit larger. Terminal nerve field fibers are anesthetized, and nerve block is a nerve trunk. The main trunks are anesthetized. So these are the different types of anesthetic techniques. So infiltration, you all very well know how we do it, isn't it? You just inject a small amount of tissue anesthesia in the area where you want. Okay. Field block, in that you have these techniques: paraperiosteal, interosseous, interseptal, intraligamentary, intrapulpal. Okay. Now intraligamentary, yeah, tell me, Radhika. You know, if you just want the anesthesia of the gingiva or something, gingival tissue, you don't want it to penetrate the bone and reach the root, yes, you can infiltrate in any tissue locally. That's not a problem. But the problem comes is when we try to use a local infiltration to anesthetize the tooth or the periodontal ligament. When we try to anesthetize the periodontal ligament or for root canal, we want the anesthesia to go through the bone and all that. In that particular case, you are looking forward. See, look guys, this is your bone and this is your tooth. If you're supposed to do an extraction, you need to anesthetize the PDL. If you're supposed to do a root canal, you need to anesthetize the root canal. Okay. Iske upar you have your soft tissue. When you actually give your local infiltration, you are just infiltrating in this tissue. If you want to do an extraction, we want this thing to go here and act here. So what thing is considered over here is, what you're supposed to consider is thickness of the bone and all that. So, isn't it? So there are many criteria. So it, you know, what is that? Video stuck. Actually, I couldn't understand her job. Video stuck? Okay. Yeah. So as far as local infiltration for extraction is concerned, you have to consider the thickness of the bone over which you are giving it. Okay. I don't know what you do in the clinic. Actually, when I extract any mandibular teeth or something, I don't think so I go ahead for local infiltration. We give a lingual nerve block. When we are giving an inferior alveolar nerve block, you just, you know, while removing the needle a little bit anterior to your thing, you deposit the anesthesia and that gives the lingual nerve block, isn't it? So particularly, you know, in incisors you give a mental nerve block. Okay. For mental nerve block, we'll be taking care of the periodontal ligament and the labial mucosa. For the lingual mucosa, yes, you can give the local infiltration and that will just block the mucosa. But your PDL has already been taken care by the mental nerve block, isn't it? So you're not expecting your lingual infiltration to diffuse through the whole bone and go to the PDL. So actually PDL you are blocking by the mental nerve block, isn't it? Okay. gather up, guys. We'll come back to the mandibular anesthesia, the bookish technique, because that's gonna be asked in exam, not what you do in clinics. Okay, so just twist your brain a little bit to become theoretical till you complete your MDS entrance examination. That's very, very, very important. Okay, even as far as the national boards and other things question, you will see, you know, and whatever is there in the book theoretical, it's quite justified. Okay, so that is something which is supposed to be applied in the clinical too, right? So we'll be talking about inferior alveolar nerve block. Now, I don't want you all to kind of mug up the list of the landmarks and all those things. I don't want you all to do that. I want you all to imagine exactly how you're gonna give the block. Since you have done it, it's not that difficult. Okay, so all you need to know here is, okay, where you are starting from. You look at the position of the needle. Okay, you're giving your inferior alveolar nerve block here. I'll just go to a few more diagrams. Okay, you see this mandibular raphe. Okay, your injection will be directed from this side. Okay, yes, and you will be going lateral to the raphe. You will be inserting your needle lateral to the raphe. You see it here. This is your raphe. Your needle goes lateral to the raphe. Which is the muscle it pierces? Which is the muscle it pierces? Buccinator. Yes, that's what I want you all to say. You know, this is the buccinator here. And what is the muscle on the back side? Which is forming the raphe, pterygomandibular raphe. What is the muscle on the back side? Superior constrictor. Okay, okay. Whomsoever says masseter, keep your hand here and clench it. The muscle which you feel here is your masseter. Okay? Yes. And when we talk about your medial pterygoid, you know, your medial pterygoid will be here. Okay? We don't actually pierce it, we go behind it. Okay? We go behind it. Between the medial pterygoid and the bone we go. Get the point over here. So the muscle which we are piercing is buccinator. The buccinator which is attached over here. Right? Yeah. So, yeah. What is the major complication that you have in inferior alveolar nerve block? Yeah, good point. Okay. So when we talk about the inferior alveolar nerve block, if you notice over here, okay, here you have your medial pterygoid muscle, and if you irritate your medial pterygoid muscle or something, what may happen is in long term there may be trismus. Okay. The second thing that we are talking about is facial paralysis. Where will facial paralysis happen? Will be happening in this gland, parotid gland. So we have to go posteriorly, right? So to go posteriorly, how your angle has to be? If by chance you moved your angle like this, if you inserted your needle this way, you will not hit the bone and you will cross posterior, isn't it? So if you insert your syringe from a little bit anterior to where it is supposed to be, a little bit more towards the center, then what will happen is you may go behind, your needle may go behind, more distal to the area concerned, and you get the facial nerve paralysis over there. Okay. One more thing, you have here some arteries over here, isn't it? So if you actually pierce those artery, which is very common thing because it's very close to the nerve, so your technique is all right, everything is fine, but you may give an intravenous injection, isn't it? Isn't it? So what do we do to avoid an intravenous injection? How many times do you aspirate? Yeah, we do a two plane aspiration actually. It's not just 2 times, it's a 2 plane aspiration. So, this is the bevel of your needle. If it is inside this thing, and then you actually turn it in 90-degree angle and then aspirate again. So basically that is a 2 plane aspiration that you do to avoid the injection. But still, if you have pierced the vessel, there is a possibility that vessel may leak over there and that may result in hematoma. What do you do if you have hematoma? What is the first thing you do if you have hematoma? First is pressure. First is pressure. Yeah. Immediately is cold. Subsequent day, after 24 hours, you start with warm and cold alternate. Okay? Yes. And yeah, when we were talking about trismus, what is the major cause of trismus? What was the cause of trismus? Yeah, there is something in the needle that is usually the one that results in tearing of the muscle and resulting in trismus. If the needle has something, what is that? That may cause tearing of the muscle while taking it out or pulling out something. Not corrosion, it is barbed needle. Okay, so barbed needle is a very common cause. What is the effect of the barbed needle? It will be trismus. Okay, so these are some few small points. As you solve MCQs, you will come to know. As we talk about the buccal nerve block is a long buccal nerve block. We just give a small infiltration kind of a thing posterior to the 3rd molar from where your nerve actually turns outside. Okay, so what is the anesthesia needed for your premolars? What is the block needed for the barbed needle? Is nothing but there is a small bent in the needle, a kind of a barb. That's it. Okay, all of you guys who saying mental nerve block for the mandibular premolars. What all teeth are supplied by the mental nerve? Yeah, basically mandibular, somewhere around mandibular first premolar to anterior. But can we give inferior alveolar nerve block in this particular case? Yeah, so if we give inferior alveolar nerve block, do we need to give the long buccal nerve block for it? No, not for premolars. Only for molars. For the buccal surface, we need to give the long buccal nerve block. Otherwise, inferior alveolar nerve block, yeah, will actually do the job for all the teeth of the mandibular region except the molars. For that, we have to add the long buccal. Okay. So, in mandible, it's straightforward. You give inferior alveolar nerve block for all the teeth. Okay. For molars, you have to add the long buccal. That's it. Right? Now, when we talk about, that was inferior alveolar nerve block, right? Now, if I talk about the mandibular nerve block, we are going a little bit above it. We are giving the nerve block to the main trunk, the main mandibular trunk. So when we talk about the mandibular nerve block, we have two approaches, the intraoral approach and the extraoral approach. Intraorally, there are two techniques. One is the closed mouth echinosis technique and the second is open mouth Gauguet's technique. Okay, so let's talk about these techniques. First, we'll talk about the Gauguet technique. How I used to remember is like, I used to remember it cow, like open mouth like a cow. You have to open your mouth very wide, and it's in that, after you open a mouth very wide, let's just go here. The landmarks are intratracheal notch and the opposite side angle. Okay, so for example, if I take angle of this side, I'll take notch of the other side, and my instrument will be like from this side to the notch of the other side. You see this? So this just the corner of this side, and we imagine the direction of the notch of that side, and what is our, where do we want to reach? We want to reach just here, just at the neck of the condyle. The landmark is corner of the mouth and intratracheal notch or tragus of the opposite side. So corner of one side and tragus of the opposite side. That is how your needle is directed. Okay? Yeah. At the level of the upper occlusal plane, you give it. You see this? Yes, for blocking the tragus wala side. Yes, we are blocking the side on the tragus. So we are starting from the opposite side corner of the mouth. We keep it because we are going back, and we have to reach to the neck of the condyle where we have the mandibular branch, mandibular nerve trunk. Isn't it? Where we have just the okay. That's one way. That is Gauguet's technique. Then let's talk about intraoral only first. Then we have the echinosis technique. In echinosis technique, the technique here, the landmarks are occlusal plane of the occluding teeth. We need to know the mucogingival junction of the maxillary teeth and the anterior border of the ramus. How do we do when the patient is not able to open the mouth? Okay, so I don't have a good picture over here, but you know how you do is, patient doesn't open the mouth much. The mucogingival of the maxillary teeth, and you keep the needle on the same side. It's something like this. For example, you're giving on this side, you just keep the needle straight on the same side and you go backwards. How do I draw? Okay, so basically this is the point of insertion. This is the point of insertion. Okay, so if you look, the level of insertion is the mucogingival junction of the maxillary teeth. That's the point here, and that's what is the MCQ asked. What happens is, we are thinking that we are giving the mandibular nerve block, so we don't consider the mucogingival junction. We have occluding teeth. Needle is parallel to the occluding teeth, but the point of entry is at the level of the mucogingival junction of the maxillary teeth. The point of entry is there. Okay, ultimately again we are trying to reach near the neck of the condyle. Okay, so that is why this mucogingival junction of the maxillary teeth, okay, is important. Clear? So that's echinosis technique. That's a closed mouth technique. For closed mouth technique, that is why we keep the mouth teeth clenched. Then we have the extraoral mandibular nerve block. In extraoral mandibular nerve block, what do we do is, we palpate the mandibular notch here. You all know this notch? This notch. Okay. The zygomatic process and and this notch. We insert the needle between that gap. Right? Insert the needle between that gap straight. If we insert the needle straight, we are going to hit something. Yeah, you can palpate it. You have your this thing. When you close and open, you will see that gap there. Okay? Between your zygomatic arch and the mandible. Right? So you insert your needle through that gap until you hit something. What you're going to hit is nothing but your lateral pterygoid plate. Once you hit that, that gives you a landmark. After that, you will retract the needle back. That means that actually tells you that you are at the right point. Okay. Then you retract the needle back and you go posteriorly and upwards to the lateral pterygoid plate. You're getting my point? So you first put the needle, you hit the lateral pterygoid plate so that you know that you are at the right point. Then you withdraw the needle back and go posterior and a little slight up, posterior and slight up to the lateral pterygoid plate, and you will be blocking and you will deposit the solution there, and that will block your mandibular nerve. Okay. Now here itself I will complete the extraoral technique of maxillary nerve block. Right? Maxillary nerve block is also the same technique. You just put it over here, you hit the lateral pterygoid plate, you withdraw the needle, but this time you go anterior and upward. You get the point? So if you go behind the lateral pterygoid plate, you're gonna block the mandibular nerve. But if you go anterior and upwards to the lateral pterygoid plate, you're gonna block the maxillary nerve. Okay? This is the extraoral technique for the mandibular as well as the maxillary nerve. All you have to do is just change the direction. Clear? Okay. Now, if we talk about PSA, now let's come to the maxillary technique. So, what we saw till now was we saw the inferior alveolar nerve block, we saw the long buccal nerve block, we saw the mandibular nerve block, Gauguet's technique, Echinosi technique, as well as we saw about the extraoral. With that, we started with maxillary by seeing the extraoral maxillary nerve block technique. Now, let's come to the posterior superior alveolar nerve block. When we talk about the posterior superior alveolar nerve block, this is the most common block which we use. You all must be knowing that. What we are doing is we are going to the posterior surface of the maxilla. The infratemporal surface of the maxilla is the place where we want to reach, isn't it? Okay. Now, how do you insert the needle? How do you insert the needle? What is the direction of the needle? Can you tell me the direction in 3 planes? Yes. It's upward, inward and backward. Every plane 45 degrees. Okay? You see this? This is, in this plane we are able to see upwards and backwards. If you look at from the front, we are able to appreciate that it is also going inward, isn't it? So that's what about PSA. Now what is the major problem with PSA? What is the main complication that is associated with PSA? Hematoma. What causes this hematoma? Hematoma is caused by pterygoid plexus and internal maxillary artery. Okay, so most common cause is hitting the pterygoid plexus. But there is a question that asks about a dumbbell shaped swelling that suddenly comes after this thing. In that particular case, take for the internal maxillary artery as an answer. Now, both pterygoid plexus and internal maxillary artery are given in Malamed it's a simple line that says that these two are the causes. As far as dumbbell thing, there has been a lot of controversy and all that, and based on the Comet case key and all that, the dumbbell type swelling, we better stick on to the internal maxillary artery. Okay, then we have this greater palatine nerve block. Greater palatine nerve block, you're very clear with. You just see the opening of the greater palatine. You all know where it is. Where it is? Which two teeth? Yeah, it is between first and second molars, and it is 1 centimeter towards the midline from the mucogingival. Yeah. So we again go from the opposite side, and we, landmark is second and third maxillary molars. Okay, and towards the midline, and we just inject in front of this thing. Here we are not trying to go inside the canal. You getting my point? We are not trying to go inside the canal. Right? We are just depositing in the vicinity so that we get. What is the main disadvantage of greater palatine nerve block? Complication. That's what your patients tell you. But what is actually the main disadvantage? The main disadvantage is necrosis. If we use with vasoconstrictor, yes, it's ischemia and necrosis of the palate. Yeah. This is the most painful nerve block, nasopalatine nerve block. In that, we actually recommend giving the, in any case, actually it is recommended that you give a spray topical anesthesia before you actually inject the needle inside. Okay, here the landmark are the central incisors, the incisor papilla, and you all wear. Actually, we do aspirate here also, Radhika, we do. Okay, because in greater palatine also we can inject in the vessels, and in nasopalatine also there is a possibility of injecting in the vessels. Okay, although these vessels are not so major that there are that much chances like we have in inferior alveolar artery over there, but yes, even we aspirate here. Okay, now look at this maxillary nerve block. We are talking about high tuberosity block. Now you all know that PSA comes out from the maxillary nerve. PSA comes out of the maxillary nerve. In the same region, if we go a little bit more higher, you are able to give a high tuberosity nerve block, and that is nothing but your maxillary nerve block. Okay. Right. So it is just, the position of this maxillary nerve is just anterior to the lateral pterygoid plate. Okay. But there is one more way you can reach it. You can actually put your needle inside the greater palatine canal, straight, and it will go and come out in that pterygopalatine fossa. You all know the pathway of greater palatine canal. It comes actually straight from the pterygopalatine fossa. So if you put your needle and let it go deep inside the canal straight, it will go into the pterygopalatine fossa, and you can give a maxillary nerve block through the greater palatine canal. And that's the, actually I've seen this technique being done. It was like, I was amazed, where is the needle going inside? It was just going so deep inside, and then it was like, yeah, that's so tricky, right? When we actually give a greater palatine, we, even if we want to, if we don't, it doesn't go inside. Okay, so it just goes inside. So this is the technique for maxillary nerve block. Okay, and extraoral technique, I already told you, isn't it? So that should be fine.